Good morning. I'm Andrew Blustein, the chairman of Garfunkel Wild, and on behalf of Garfunkel Wild, I want to thank you for attending the 10th annual ASC and Healthcare Management Symposium. And yes, we are starting exactly on time. It's hard to believe that it's been 10 years since we started this. And based on the collective feedback that we had, we decided to remain virtual, obviously, this year again. Now, I know this does reduce the in-person FaceTime with over 300 people that have registered, but it does have a lot of advantages in terms of travel. So we hope for those people who wanted it in person, sorry, and for those who wanted it virtual, you got what you wanted. But this virtual event could not have happened without the many speakers who came up with ideas, created presentations, and in some cases collaborated with people they actually compete with. This could also not have happened with the many people who help with the marketing and IT, including Miguel, our excellent IT support, and especially my partners, Kim Kempton and Greg Bloom, who spent a lot of time helping create the event, and also Mandy Kaplan, who's been sending out a lot of emails to organize it. But mostly, this event could not have happened without all of you, especially those of you who gave us ideas for today's session. And we have a jam-packed agenda. Before I turn it over to my partner in crime, Greg Bloom, I want to make one programming note. There is a live session. I am live, okay? And the next session will be live. But there will be a final live session at 3:45 to 4:30, where many of the speakers will be returning to answer questions. So if during a session you say, I wanted to ask this question, you can send it to, and grab a pen, you can send the questions to mkaplan, Kaplan, at garfunkelwild.com. That's mkaplan at garfunkelwild.com. If you don't get a chance to do that, then when you join to the 3:45 live Zoom session, there's actually a place for you to add questions in the Q&A, and we will try to handle those on live as they happen. So with that, because I know you'd rather hear from our next speaker than me, I'm going to exit the screen. I will see you all at 3:45 this afternoon, and ask Greg Bloom to take it away.
Good morning. My name is Greg Bloom, and I'm a partner director at Garfunkel Wild and the co-chair of Garfunkel Wild's corporate department. I, like Andrew, want to thank you all for joining us today for our 10th annual ASC and Healthcare Management Symposium. I'm going to keep my introduction brief today, as most of you know our speaker very well, since he has been with us for each of the 10 years of our symposium. And Bill, we thank you very much for sharing so much knowledge with us over those 10 years. Bill Prentice is the Chief Executive Officer of the Ambulatory Surgery Center Association and the Ambulatory Surgery Center Association Foundation. ASCA is the national organization representing the interests of more than 6,000 ambulatory surgery centers in the United States, and provides advocacy, education, benchmarking, and staff training for its many members. Under Bill's tenure, ASCA has achieved record membership numbers, significantly increased revenue while reducing expenses, developed a number of mentorship programs and services, and dramatically strengthened its advocacy efforts on Capitol Hill with relevant federal agencies. While Bill's been with us for 10 years, we're going to have a somewhat different format for his session today, with me asking Bill a series of questions on some hot topics affecting ASCs. We hope you find this helpful, and if you have questions along the way, feel free to send those in to the Q&A tab on your Zoom link, and we'll try to get them covered in the live Q&A session at the end of the program. And with that, I'm gonna start out with my first question for Bill, which I think everyone wants to hear. It's usually how he starts his presentation. Bill, the proposed ASC Medicare payment rule for 2024 was released recently. Can you give us the highs and the lows of it?
Sure. And one, thank you, Greg and Andrew and everyone at Garfunkel Wild for putting on this conference and providing education to the ASC community. It's always a great time to spend a few minutes with you. Medicare rule, yeah, we're in the proposed rule process. As you mentioned, the rule came out in July. Um, the comment period ran until the September 11th. So we had until that time for thousands of people to submit comments to that proposed rule. Obviously either supporting provisions in it or asking for why certain things weren't in it, including ourselves. We're a few weeks away from that rule actually being finalized. So we'll know actually what's in that final rule on or about November 1st. And that'll give us 2 months to obviously digest it and for surgery centers to implement whatever changes are being asked of them in that final rule. When I think of the highlights, if there's anything just to highlight, it's the fact that we are still being updated for inflation using the hospital market basket, which is the same inflation factor that the hospital outpatient departments are using. And the value of that is obviously, making sure that, we don't go back to the time when we had separate inflation factors and ours generally was being outpaced by the hospital market basket, meaning that every year we were falling further and further behind the hospital outpatient department in terms of our reimbursements. Doesn't fix our problem, but being on the same inflation factor at least reduces that delta a little bit. We were actually due to, there was a 5-year pilot to keep us on that market basket that was supposed to expire this year. So one of the things that we had been calling for was for CMS to extend that pilot and keep us on that hospital market basket for at least a couple of more years because of the pandemic. And so we were very pleased to see that in the proposed rule, CMS was agreeing to do that. Now, obviously, our end goal is to actually have it finalized that we are permanently put on the hospital market basket. But at least, if they hold true to what was in the proposed rule, at least for the next 2 years, we'll stay on the market basket. When it comes to things that, a low light, I would have to say it's the procedure list. As many folks know, we have a prescribed list of procedures for which an ASC can be reimbursed under Medicare for treating a Medicare beneficiary. And that list is smaller than that of a hospital outpatient department. And so every year we are trying to bring clinical data to CMS about the procedures that ASCs are safely performing on commercial patients, including patients that are nearing Medicare age, that we believe we should be able to be reimbursed for treating the appropriate Medicare beneficiary. So we brought close to 60 procedures to CMS this year that we believe fit that profile. And we're extremely disappointed that none of them were included. In fact, the only codes being added were a number of dental codes. And there's a reason for that, but even that they didn't get quite right. But we are particularly distressed, for example, that total shoulder, which is a procedure we've been asking for a couple of years, and which is on the hospital outpatient list, that we're still not allowed to provide any to any Medicare beneficiary, even the healthiest, a total shoulder arthroscopy. The fact that we can do total knees and total total knees and total hips, but not do shoulders, really is nonsensical. And it speaks to some flaws in, I think, the decision-making process at CMS that we need addressed. And indeed, we actually have a call later this morning with a lead official at CMS to actually talk more about that.
First of all, thank you very much for the hard work. It makes absolutely no sense that you could do knees and hips and not shoulders. And keep pushing them. I'm sure there are a lot more on that 60 items that are important.
Additional spine procedures, cardiac procedures. There's a whole host of procedures. Indeed, we don't think there should be a distinction in terms of what an ASC can perform versus a hospital outpatient department. The only distinction that should be made is the clinical judgment of the surgeon about where is the safest setting for the patient. Which is, the process that, every ASC surgeon already uses when making decisions off of the current procedures. We would just be doing the same thing with any additional procedures we receive. So that's, I think, the missing link with CMS, that they don't understand that, It's that clinical judgment of appropriateness of setting that should be the determination, not just a line in a regulation.
Right. Makes sense to me, and I'm sure most of our audience, but thanks, and keep us posted. Moving on to other topics. Site-neutral payments are receiving a lot of attention in Washington. Why is that, and how would surgery centers fare in a site-neutral environment?
Sure. So the idea of site-neutral payments has been around. This concept has been brought up numerous times over the years, particularly by the MedPAC Commission, who we may talk about a minute or two later, which is an organization that advises Congress and CMS on Medicare policy. And they, for a long time, have taken the position of questioning the fact that the site of service dictates a completely different facility payment. And so, for example, if you did a total knee in an inpatient hospital, you would get charged X. If that procedure was to be performed on a Medicare beneficiary in the HOPD, you get paid Y. And if you were performing that procedure in a surgery center, you'd be paid Z. And obviously, it's gone from higher payment to lower payment in that example I've made. And so the question that is being asked increasingly, not just by MedPAC, by a lot of lawmakers on Capitol Hill, is why does that happen? Why should the hospital get paid so much more than the surgery center for performing the same procedure, with the same clinical team? And so that has started to receive some traction on Capitol Hill. I doubt that anything will really happen over the rest of this congressional cycle. But I think a lot of policymakers are starting to really look at that. The concerns that we would have is that, you're asking, how would that impact ASCs? Well, in a perfect world, what would happen is that, our policymakers would construct an appropriate payment that would incentivize care to go to the lower cost setting, but not make it impossible for the higher cost setting to treat the patients that only they should be treating, right? Because there are patients that have comorbidities that deserve to be seen in a hospital, have a greater risk of something happening, and that higher cost setting should be paid more to assume that risk. That's really not the way people are thinking about it, though. And I think the expectation is that if a site-neutral policy were implemented, it would probably drop things down to the lowest, rate, which would be, the surgery center rate. Meaning we wouldn't benefit from a payment standpoint by a site-neutral policy. What we'd benefit from, obviously, would be volume. That would be a tremendous amount of volume that would come the surgery center way, because the hospitals would no longer see a way to get reimbursed appropriately to provide that care because of their higher cost.
Right. So while we may push for it to get some volume, I guess, on the hospital side, they'd probably be against this because they're going to lose reimbursement.
And quite honestly, I think, we from a policy standpoint, I think, we would recognize that we would be getting volume that perhaps doesn't really belong in the surgery center setting. Again, going back to that clinical judgment of the surgeon, I think she might say, hey, this case should really be done in the hospital, but if the hospital won't do it, what happens? So you could have, a gap in care there that I don't think anyone would want. So our hope would be that in constructing a site-neutral policy, what we would really ask for is something that is done much more thoughtfully and done with a scalpel rather than a battle axe. So that that's the type of thing we're looking at. For example, there was a legislative proposal introduced, discussion draft of a bill. It was never actually technically introduced, that would have actually potentially set reimbursement at the physician office level for some procedures, which was created a problem for us as well.
Right.
I mean, so that's the other thing is it's not just a, site neutral between hospitals and surgery centers. There would also be site neutral policies between surgery centers and the physician office that would complicate our lives as well, and also potentially create access and patient safety issues. One of the things that I'm sure a lot of the ASC attendees on this call are aware of is the fact that there already is actually a site neutral policy. It's not referred to that way, baked into our reimbursements, which is that once a procedure that is on our ASC list, once CMS sees volume from a year showing that more than 50% of that volume is now being performed in the physician office, we've seen that happen with some pain codes and other things, we actually lose our facility fee.
Interesting.
automatically because of the volume. And there again, that's showing, I think, a lack of irrationality on the part of CMS. But just because slightly more than half the patients are receiving care in the office for that procedure doesn't mean 100% of the patients can safely be seen in the physician office, because again, the regulatory standards of a surgery center relative to a physician office is dramatically different.
Of course.
We're basically clinically identical to that of the hospital outpatient department. So, there's an example where, again, I think CMS has kind of misaligned its priorities and not understanding there are still some patients that would be better seen in the higher regulated surgery center setting, and therefore, there should be a facility fee attached to that procedure.
Okay. Well, it wasn't my next question, but since you brought up the MedPAC Commission and its role here, what role do they play in what Medicare does? And do you have any insight into upcoming recommendations that they have?
Sure. So the MedPAC Commission was created by Congress probably 30 or more years ago as a kind of just an advisory body to both Congress itself and to CMS and the Medicare program to basically come up with suggestions on how to improve Medicare policy and make the program run better. The problem with the MedPAC Commission, has always been kind of heavily populated with representatives from academic medicine and hospitals and health systems. And therefore, they do not have a really good understanding of the surgery center setting and the value that we bring to the Medicare program. So they have unfortunately been almost consistently wrong in terms of their advice to CMS and Congress about how to treat surgery centers. So we've been long looking to try and get a surgery center representative on that panel, hoping that we can embed somebody who actually understands the way surgery centers operate. We would have a better chance of getting them to tailor their policy recommendations with facts rather with a lot of mistaken beliefs about the way surgery centers operate. And the greatest example I can show of where they've been misguided is that they have historically recommended a 0.0% inflationary increase for surgery centers for the fact that we do not provide cost reports to CMS and the issue there is that, they're trying to punish surgery centers for the fact that the agency sees no value in asking us to provide cost reports. And there's a really good reason why we don't provide cost reports. We don't have a payment system. Almost every other provider type has a payment system that's developed to actually analyze and construct their payments for Medicare procedures. We are only paid a percentage off of the hospital outpatient department payments. So there's a payment system for which we're attached to, for which there is, cost reports, but we don't have our own payment system. So it makes no sense. So unfortunately, the MedPAC Commission is, generally wrong when it comes to its positions on surgery centers. The only upside is that the agency has pretty routinely ignored their advice when it comes to us, because I think they also recognize that they're not getting really good information from MedPAC when it comes to our program.
Okay, well, thanks. And I guess this will be a running theme. Thank you again for all your efforts on behalf of all of our registrants and centers and the community. We really appreciate the work you do, Bill. Changing topics. Can you tell us your view on the status of the implementation of the No Surprises Act and its impact on surgery centers?
Yeah, I think the No Surprises Act is, a prime example where there was like a legislative, concept that was enacted, and once it was handed over to the regulatory agency to implement it, things kind of went sideways. Because I think that there was, a lot of support overall for the idea behind the No Surprises Act of trying to provide ways for patients, we are all patients, to make sure that they're not being surprised by bills from a medical procedure that they weren't aware about. And I think there's all sorts of examples we've seen probably in our own families, our own lives, where that has occurred. And so an effort to try and do away with that made sense. The problem is the way that the agency is implementing the No Surprises Act is creating a lot of stress on providers and the provider community in particular, in terms of the way that they're trying to implement it. And there's been a lot of litigation over the No Surprises Act. The Texas Medical Association, which plays a very kind of interesting role in healthcare, in that they are always the first, it seems, to go to court over things that the House of Medicine doesn't like, has been trying to make a lot of changes to the way that this rule has been implemented. I will tell you that in practice, probably the impact on the surgery center itself has been somewhat nominal because one, all our care is scheduled care. So it's not hard for us to tell our patient ahead of time what the cost of that care is going to be in our building. I think where we've seen the negative impact is the impact on other providers such as anesthesia, which has resulted in, I think, some disruption in that space and made it hard in a lot of markets to get the anesthesia care we want at the price that everyone can afford. So that's something that needs to be played out. The agency continues to try and revise the regulations around this. I think some new regulations just came out recently that I think continue to muddy the water about how this is going to work and how the dispute resolution process is going to work. And there's still an issue that you can't batch claims. If you have a number of similar problems with a payer, you can't batch those and send them in one fell swoop. That needs to be addressed. And I will tell you that we're in the first couple of years, I think the Congress was a little bit agnostic about revisiting this issue. I think there is a greater awareness on Capitol Hill that this isn't going the way they thought it was. And I think there's an increasing likelihood that at some point down the road, we might see Congress step in and try and kind of make some corrections to this, where I think they believe the administration has overstepped and taken some misguided steps in implementing the No Surprises Act.
Right. And hopefully sooner rather than later, because we know of a lot of people struggling with this. There are claims in the IDR process that are languishing, people not getting paid. So hopefully sooner rather than later.
Well, we got to have the House get a speaker first as a starting point before we get any more legislative action. So
and do a lot of things. So let's hope that can get behind us. So Bill, quality of care is always a hot topic for both payers and patients. What's ASCA and the ASC quality collaboration working on that we should be aware of? And related to that, what's the status of the OAS CAP survey requirement?
Yeah. So for those who don't know, the ASC Quality Collaboration is kind of a sister organization to ASCA that is funded by the ASC community, our large management companies, some of our large states, and ASCA to develop quality measures for our CMS quality reporting program. And I think we're unique in that role that I don't know of any other provider community that does this on its own. A lot of the other quality measures that you see come out for hospitals and providers are actually created by, other organizations like Yale, New Haven, and RTI under contracts with CMS and receiving federal dollars. We actually do it on our own on a shoestring. And I think we've developed really good targeted measures because we're obviously focused on the measures that make sense to us. Unfortunately, CMS also then adds measures to our program that come out of that other process. So we've seen some really kind of wrong-headed measures being applied, for example, about the COVID vaccine reporting, which is something I know that has bedeviled our members now for a couple of years and are hoping will go away. Unfortunately, in the proposed rule, there was no effort to try and do away with that measure. We have actually commented vociferously, both in our comment letter and in individual meetings with CMS staff, that this measure makes no sense and is an undue burden. But we continue to hope that we can develop measures that make sense to our members and that also then can show to our policymakers and to our patients the high quality care that the surgery center setting is providing. And as much as a burden having this quality reporting program is, I will tell you that it has done an amazing job for us in terms of turning the heads of those policymakers and others in terms of being able to show that the quality of care we're providing is every bit as good, if not better, than our competitors in the healthcare marketplace. And before we had that program, it was unfortunately too easy for our competitors to try and demean or question the quality of that care. They can't do that anymore. Now, the last part of your question was about the OAS CAPS survey, which is a long, lengthy, patient assessment survey, post-care survey that was developed by CMS. That's 34 questions long, which, if you think about your own patient satisfaction surveys, I mean, that's insane. but for which is being implemented this coming January for hospital outpatient departments and is scheduled to be implemented in the surgery center space in January 2025. So while there is always, some faint hope that in this final rule that'll come out, there'll be some kind of extension applied regarding that program, we're very doubtful that that's going to happen. Now we're always going to be trying to, change the survey and have it, the scale of it being reduced. But right now, I think the expectation is that come January 2025, surgery centers are going to have an outside vendor to implement this lengthy, patient satisfaction, to use, kind of a term, survey. And unfortunately, you're going to have a vendor that can, use all the modes that are required, which includes phone, mail, and email. And unfortunately, there is still no electronic only option available. So you're not able to just send out an email and hopefully get the 200 required responses for this. You're going to have phone and mail as part of it, which is expensive and burdensome. But again, our concerns about that have fallen on deaf ears with the agency. I will tell the listeners there that are in the crosshairs for this: do not delay, do not wait. It takes a lot of time to find the right vendor for you, and to get this up and running and to get the responses you want. I think one of the things that anyone who's done a patient satisfaction survey has realized once you've implemented it, that the things that you thought you were doing really well, you're not getting the responses the way you might have expected. You might have thought that, Mary out front, everyone loves Mary out front. She does a great job, welcoming people. And then you're going to find out on your survey that maybe she isn't doing as good a job as you thought. And you're going to need to do some training there to get the responses you want. There's also, I think, experience from people who have implemented this earlier to realize that because of the way the questions are framed, you want to make sure that you're speaking in the same language to your patients so that when they get the survey, they understand and answer the questions the right way to give you the response that you deserve. So there's a lot to this. So I really would encourage folks to find a vendor sooner than later and negotiate a good contract and get to work on this. I will say that, there's 15, I think, approved vendors that CMS has identified that you can find on the CMS website. You can also find those vendors on the ASCA website. The largest of whom is Press Ganey, who obviously, many people know about. We've actually engaged with Press Ganey at ASCA so that ASCA members, if they use Press Ganey, can get a discount for using them. We continue to work with them to try and educate them about the ASC space, because I know that some early adopters didn't think that the Press Ganey folks really understood the differences between a very small ASC administrative team versus that of a hospital. That's still a work in progress, but we'll work with them and any other vendor to try and make sure they understand our setting better and can treat their customers better. But again, I think this is something that it's looming. Doubt's going to get delayed, and folks should really start to get the work done of finding a vendor and getting this process started.
Okay. Well, first, again, thank you for that. And little plug, obviously, along with ASCA, your friends at Garfunkel Wild are here to help you with those agreements.
Great. Good.
And while
Greg, on that point, because the one thing is that, if you're signing a contract now and perhaps maybe there would be a delay, either this year or next, make sure you build into that contract the ability that if there is a delay in terms of the requirement, that then there would be a delay in actually having to, use the survey,
Right. And while there are administrative challenges and the length and the cost of all this, going back to what you said earlier, hopefully these surveys show how great our centers are performing and come out good for the centers.
Well, I think I'm very confident that will be the result, that once there's public reporting of this data. I think once again, and as we've seen almost every other time, there's been a comparison of the quality of care or the patient satisfaction, ASCs have come out on top. And so. Great.
Again, not staying in the order of what I was going to ask you, but things that you've brought up, and you mentioned how there was some misperception about how ASCs are doing. We recently went through a wave of some negative press about ASCs, which thankfully seems to have died down now. Are there any other negative issues or hurdles that you see people talking about or on the horizon for our centers that we should be aware of?
No, I would tell you that I think because of the hard work that we have done on the quality side, and in terms of telling the story and protecting the reputation of surgery centers, and if you're talking back that a few years ago there was that ridiculous Kaiser Health News USA Today effort, which quite honestly just fell on its face because the facts didn't back up what they were alleging, and I think you saw from a policymaking standpoint that it just completely just disappeared because again it just was so discordant from what the facts showed, that it kind of just disappeared. So I think on that side, I think we're really in a good position. I will tell you where we have trouble and we have to worry about though is just these overarching concerns that legislators have about the cost of healthcare, and I think misidentifying the causes of it and misidentifying the solutions for it. And so, as an example, we had an effort in the past year where a very large state with single party control, meaning they controlled the governor's house, the Senate, and the lower house, actually considered legislation to eliminate facility fees for healthcare settings. I'll let that sink in.
Yeah.
Eliminate facility fees.
You might as well close close them all.
Well, so if you want to think, I mean, that's both hospitals,
Right,
surgery centers, and other settings of care that they didn't understand the fact that the facility fee paid for everything other than the physician's, services. I mean, that's extraordinary. Now, the punchline to this story is that people are probably in their head going, large state, single party control, probably thinking that was California. It was not. It was Texas. This was a conservative Republican state that didn't understand the value of, a facility fee to keep a business running that provides
total misunderstanding of how the business operates.
So that speaks to the threats that are out there for us because just people don't understand the way healthcare is, operates and why we need to be vigilant both at the federal level and state level to make sure that we're explaining all these things all the time to our lawmakers so that nothing like that ever actually got enacted into law.
Okay. So going back to a topic that everyone usually waits for in your discussion is what's ASCA focused on. State legislators generate thousands of bills each year, many health care related. Can you touch on some on which ASCA is focused? For instance, transparency on facility fees, I know. What's ASCA's take on those?
Yeah, I think that, as I mentioned, I think, there are obviously tens of thousands of bills introduced every year in every state. And, we try and monitor all of those to make sure that we know, what's popping up in every state in the country. And then obviously trying to work with our state associations where we have one to try and make sure we have a coordinated response, which is something, for example, we did with our friends at the, Texas ASC Association on this facility fee bill. Healthcare transparency is another one, despite the fact that we're, as we just talked about, we're not even fully implemented with the No Surprises Act. We're seeing a lot of efforts at the state and federal level to implement or require providers to provide more transparency about cost and prices, which, really, it seems to me doesn't make sense. I mean, let's get the No Surprises Act, fully implemented, and then any patient who chooses can find out the cost of her care through that process. But yet we're still seeing both in Congress and in various states requirements to have to post prices on a website of your 300 most common procedures. Many ASCs don't even do 300 different procedures. So there's a lot of burden that's being offered up to healthcare providers that, quite honestly, I don't think provide any value to the consumer, to the patient, because I doubt they'll actually be used by the patient. But are going to come at some cost to the provider that's only going to raise costs. So that's the type of thing we're trying to remain vigilant on and trying to provide good response to. We obviously support transparency because we are the lowest cost provider when it comes to surgical care. If we can get that word out, we're obviously going to, I think, do quite well there. Same thing with regards to quality, as we've talked about. The more that a consumer, a payer understands both the quality and the lower, cost of care in the surgery center, we win. But again, it has to be done the right way. And I think, unfortunately, we're seeing a lot of kind of, ill thought out processes that are going to be required of us that aren't really going to provide, good information to a consumer, and it's just going to add to our costs.
Great, thank you. So turning to overnight stays, we know that certain states allow them. New York doesn't. Have you heard any discussion about the expansion of overnight stays to New York or other states?
Really have not. There's some issues there where, regarding, how from CMS about how those are implemented, because you're really not supposed to treat Medicare patients different from other patients. And so how, and obviously CMS has a 23, hour, 59-minute, requirement. What we have seen, though, there were many states that had actually more restrictive requirements than CMS when it comes to that stay policy. And we've seen some of those being lifted so that patients can stay in the surgery center, for that 23-hour, 59-minute period if necessary. And states like Pennsylvania, which actually had a very restrictive requirement about the length of time a patient could be in a facility, that truly limited the types of procedures that could be performed there. That's been done away with. So I think that's allowing surgery centers to at least see all the patients that they should be seeing, and obviously able to keep that patient there long enough to make sure that they can get home, safely. But I'm not aware of recently any changes where people have gone beyond that at the state level.
Okay, thank you for that. So the Federal Trade Commission has proposed regulation to ban non-compete clauses in employment contracts. What do you see happening with that? And do you think it will apply to ASC ownership interests as well?
Well, I mean, that's, as you're probably aware, Greg, that's a very broad regulation that, applies to all for-profit businesses in the United States. And, that's obviously they've received, I don't know, tens of thousands of comments since that rule was proposed. And I think we're not expecting some kind of final resolution on that until next spring. Currently what I'm hearing. I would say that, in looking at that regulation and thinking about its application to surgery centers, the thing that we really kind of stuck out to us was the fact that, as I mentioned, this regulation applies to for-profit businesses, meaning it does not apply to non-for-profit businesses, including not-for-profit hospitals. So the thing we really wanted to point out with the fact is that that's creating a real distortion in the marketplace if this were implemented that way, because the not-for-profit hospital would still be able to use, these non-compete clauses with its staff and its physicians, but the surgery center in the same marketplace wouldn't. And we think that doesn't make sense. We also think, by the way, when it comes to non-competes, the leadership teams in surgery centers and the surgeons clearly have the ability to negotiate on their own behalf and are not at a disadvantage in terms of determining whether signing a non-compete clause is in their best interest or not. I certainly understand that there are, an abuse of non-competes in the marketplace, particularly with, many, non-white collar employees being forced to sign these. That needs to be addressed. But I think this regulation is overly broad, and I'm hoping that, the volume of comments they received, this will penetrate through to them, and they'll come back with a much more narrowly focused regulation on non-competes that doesn't create problems for the surgery center space.
Okay, and we would agree with that. So hopefully you have some pull in that.
Hey.
So in our crazy world that we're living in and crazy economy, we see more and more states in financial distress. We've seen some of our local states tax surgery centers in Connecticut. Do you think that with the financial distress and state issues going on, that we'll see the creation of more taxes on ASCs? And are you aware of any proposals in the pipeline on that?
No, actually, fortunately, very recently, we're not seeing a lot of movement there. I think where we're seeing a lot more activity when it comes to the financial pressure states are feeling is in, lowering reimbursements for Medicaid and other care that's under their control. And so as a result, I think that that's really the focus that we're seeing is trying to, stave those off and recognize that they're creating access to care problems by not, funding these programs properly and not setting reimbursements properly. So not to say there's not threats that way, but we've actually seen in a couple of states it actually go the other way, where some provider taxes have been repealed in places like Connecticut and Wisconsin. So if anything, maybe there's a slight trend in the opposite direction. By the way, I saw there was one question in the chat that was, asking about, the proper reimbursement for hospitals and how do we maintain hospitals? I'm kind of paraphrasing the question, while still, getting care that belongs in the surgery center and the surgery center. And my answer to that question is, because this comes up all the time, it's like, we never lobby against hospitals. We don't lobby against fair reimbursement for hospitals. I think the problem that, our healthcare system has adopted for too long is the construct that cross-subsidization is the right way to go when it comes to reimbursing hospitals. So the problem is that if a hospital is not fairly reimbursed for treating providing the critical care that it needs to, let's address that directly and get them reimbursed properly for that. Let's not make every other patient that goes into a hospital overpay to subsidize the care that only a hospital can do. And I think we can get our policymakers to focus on that. I think we have a better chance of reducing the cost of healthcare, because quite honestly, I think that hospitals for too long have kind of used that as a crutch to prevent really, some really thoughtful restructuring of payment policy to get them paid appropriately for things only they can do, but probably is going to result in them getting paid less for some of the things that can be done in other settings at a lower cost at the same quality.
Right. So Bill, I have so many more questions for you, but it looks like we're running out of time, and I want to give you an opportunity for something that I know you always want. First of all, thank you so much for your time and providing us your valuable insight year after year in 10 years. We can't thank you enough. So how could our folks online here get involved in advocating for the ASC model and at both the state and federal level?
Yeah, I thank you, Greg. Always a pleasure to be with you, and I hope that you have a great rest of the day with this program.
Thank you.
As I always say, we're a very small team at ASCA. We are grossly outspent and out. We have much fewer staff than our competitors. In Washington D.C. and in the state capitals. The hospitals, as an example, have a tremendous more number of folks advocating for them than we have in our space. The only advantage we have when it comes to our advocacy is that we're generally right on the issues, which I think matters. But it only matters if people can hear our right policies. And so what we need is the ASC community to be much more proactive in terms of meeting with their lawmakers, meeting with their policymakers, and telling them about what you do and the care that you're providing in your community to their constituents at high quality and a lower cost. And too few lawmakers understand what a surgery center is and understand how many they have even in their legislative district. So if we have ways through ASCA where my team can help you to set up, for example, a facility tour with your lawmaker, to have her come visit your surgery center and walk through and see what you're doing, I will tell you nothing makes a greater impact in terms of making them understand what you're doing than to have them come visit your facility. And we're happy to help you do that. You can go to the ASCA website and connect with my staff, and we will help you to do that. We also have a Washington Advocacy Day every year where you can come visit your lawmakers here, and we help you through that entire process. But really, I think if you will help us to advocate in your behalf, I think a lot of the challenges that we're facing can be overcome. And I think we have a great chance of not only preserving, but really, growing the ASC community and the care that you're providing to patients. So I hope you'll take me up on that. And with that, I'll stop. Greg, thank you again for this opportunity, and hope you have a great day.
Thank you very much, and thank you again. And I will stress, I do hope people take Bill up on that, because he works really hard for our entire community. And again, Bill, thanks again for 10 years of knowledge for our registrants. And now I'd like to turn this over to my partner, David Traskey, for his session on the OIG's focus, what healthcare providers need to know.